For anyone who's ever been told their spine is degenerating or that they're a millimeter from paralysis, the fear can be as debilitating as the condition itself. But what does spinal stenosis actually mean? When is surgery truly necessary and when is it not? And what does recovery really look like? My guest today is Dr. Allan Levi, a tenured professor and chairman of the Department of Neurological Surgery at the University of Miami Miller School of Medicine, chief of neurosurgery at Jackson Memorial Hospital, and holder of the Mary M. and Sash A. Spencer Endowed Chair in Neurological Surgery. Dr. Levi completed his residency at the University of Toronto and a spine fellowship at the Barrow Neurological Institute, and holds a PhD in neuroscience from the University of Miami. With over 30 years of experience and thousands of patients treated for cervical and lumbar stenosis, Dr. Levi's expertise also includes his research funded by the NIH and Department of Defense, pioneering work in cellular transplantation strategies after spinal cord injuries. In full disclosure, Dr. Levi is also my neurosurgeon, and a year ago, he gave me my leg back. In this conversation, we explore what lumbar spinal stenosis actually is, why imaging findings don't always match symptoms, and the full continuum of care, from physical therapy and epidural injections to surgical interventions. We discuss how to find the right spine specialist, why you should be wary of any surgeon who says you need surgery tomorrow or you'll be paralyzed, and equally, why waiting too long can lead to permanent nerve damage. This is a conversation I wished every patient could have before making decisions about their spine. Welcome to the Live Aligned podcast. I'm Dr. Brent, a doctor of physical therapy, professor, founder of Polestar Pilates, and pathokinesiologist. For over 35 years, I've been fascinated by the dynamic relationship between movement and pathology. On this podcast, I'll host special guests and friends who are making meaningful contributions to help us live aligned and be kind. Experiencing back pain again after lifting groceries, shoulders screaming after a good game of pickleball, even after working out in the gym for the past 6 months? How can you improve the control of your newfound strength and mobility? Strength and mobility should be experienced simultaneously and naturally. Polestar Pilates teachers are taught the principle of control and its relationship to strength and mobility. Looking to move efficiently with control? Find a Polestar Pilates graduate near you. Go to the Polestar Pilates website, click on Find Your Graduate, and search for a professional in your area. If you're ready to begin your own training, go to the Polestar Pilates website, choose your course, and use the code Dr. Brent, the code DRBRENT, to receive 10% off your tuition. And now, my conversation with Dr. Allan Levi. Welcome to the show, Dr. Levi. Good to have you here. And just full disclosure, a year ago this month, you performed surgery on my back for lumbar stenosis, and just a public expression of gratitude. Those who have known me know that I was pretty miserable for a number of years and have seen me this year traveling, working, and I have my left leg back. So thank you publicly. You know how much I appreciate your work. Good to have you here.
Hey, well, you're so welcome, Brent, and thank you so much for the invitation.
So today I wanted to specifically focus on lumbar stenosis, and more importantly is your role as a neurosurgeon, both informing, communicating with our clients, our patients, about what is stenosis and what are sort of the progressions that are followed medically as and maybe before surgical interventions are considered, and then when surgery is necessary, what does that look like for our patients? Can we start off with maybe just giving a layman's definition of spinal stenosis?
Absolutely. I'm happy to do that. I think maybe it might be appropriate just for me to give your audience a little bit of my background. And I think that's probably important because a lot of different specialties take care of spinal stenosis, anywhere from physical therapists to neurologists to rehab doctors to neurosurgeons. And I think we all have a little bit of a different view of things. And I think this is part of the reason of your podcast is to try to get different opinions about medical problems. So as you had indicated, I'm a neurosurgeon. I'm actually the chair of neurosurgery at the University of Miami School of Medicine and have been doing this for about 30 years and have taken care of, I would say, thousands of patients with both cervical and lumbar spinal stenosis. We're going to focus on lumbar spinal stenosis, and lumbar means the lower back. And the lower back has 5 vertebrae. And they are sort of something that you're given once in your life, and that we are an erect species. And because of that, we put a lot of weight and wear and tear on our lumbar spine. And because of that, and because in part of genetics of individuals, you can be prone to a condition that we call degenerative or osteoarthritic. Osteoarthritis simply means wear and tear of the bones and joints. And so lumbar spinal stenosis is a condition where there is wear and tear in the lumbar spine. And as a result of that, you get enlargement of the joints in your back. We call them the facet joints, but they are just joints in your back, just like there's joints in your fingers, and they can enlarge. In addition, you have discs in between the vertebrae, and those discs can bulge. And so the combination of disc bulging, facet joints growing, start to encroach on what we call the spinal canal. And the spinal canal is what harbors the nerve roots that go down to your legs, control your bowel, bladder, and sexual function. And once they become compressed, you can start to experience symptoms. Now, the diagnosis can be made on a clinical grounds, or it can be made on imaging. And I'm sure we're going to get into the differences there. But that's essentially pathologically and pathophysiologically what lumbar spinal stenosis is. It tends to be degenerative, but I would tell you there's something called congenital lumbar spinal stenosis. And as I told you, there is often a genetic component to these things. There are some people who are inherently born with small spinal canals. And those people who are born with small spinal canals will be more likely to develop symptoms because they just have less room to start with. So there's congenital spinal stenosis, you have degenerative spinal stenosis. Those are some of the definitions to start with.
That's great. And that helps a lot. And I think that what I remember seeing a study that was looking at the incidence of stenotic incidents as well as degenerative changes in the spine. It was looking at a large demographic, but individuals that had never had major back pain or any kind of radicular pain. And it was very interesting to realize how normal that is in our aging population, that if we took a demographic of, let's say, over 50, over 60 men and women that have been active in their life, never had back pain, if we did MRI of all of them, we would see a lot of these degenerative changes, even though they could be symptom-free. Is that correct? I mean, I saw that study and it sort of gave me a little bit of comfort because there's times where I see patients that will complain of some low back pain, and there's a million things that can cause mechanical low back pain, but they get an MRI and of course they have a major degenerative change, but they don't have any hard neuroscience. They don't necessarily have the weakness in the legs or the bowel and bladder dysfunctions. And sometimes with the conservative care, we get rid of the mechanical low back pain, but they still have obviously the stenotic changes and also some of the degenerative changes of the disc and the vertebra. So for example, I might see a patient for a while with different lumbar and radicular symptoms before I would send them. And if I can't make the changes in a couple weeks to a couple months, I want them to have a surgical consult. and they come in and you go through your differentiating diagnoses. With you, I can only use myself as the example. And I was thinking back of how I had presented to you, and my biggest concern was actually my left knee. And it was like the knee, I was gearing up for mentally for possibly a total knee replacement, but I was also having foot and ankle, and I was also having hip, and it was very frustrating for me. And the first thing you did was prescribe an epidural, almost more diagnostically. And I went in and had that epidural, and what you had seen, and I guess this is sort of how I would assume a lot of my patients think as well, and that's what I want to get to. I was thinking that I knew I had stenosis at L5S1. And it didn't make sense to me medically or physiologically of why I was having so many troubles in the whole leg and a little bit of bowel and bladder kind of stuff. And when you had looked at the MRI and you had realized that, well, your stenosis is a lot worse than just the lumbar. It's also bad up at 3-4 and 2-3. And you had prescribed an epidural. And that epidural was very clear that that particular segment was where I was getting encroachment on that left foramina that was causing the majority of my pain and symptoms. It was almost like instant relief for about a month after that epidural. And then we played with that for a while, and then we sort of realized that that is where the problem was. And then you decided that, well, you told me from the beginning, it's surgical no matter how you slice it, but we can try to avoid it based on the travel schedule I had. And then we got to the point where we really did need to do the surgery. The epidurals weren't cutting anymore. What would be a typical progression of diagnosis from your perspective as the neurosurgeon? Person comes in, has neurological symptoms. Am I a pretty standard case of how you would progress with that differential diagnosis?
I think so. I mean, everybody's different. Everybody has different levels, of involvement. Some people are one level, some are multiple levels. Some people have instability associated with their stenosis. Getting back to your original statement, there's a lot of people who have no symptoms and have spinal stenosis on imaging. I know myself, I've had a CT scan for a kidney stone, and when I looked at my lower back, I went, wow, I have spinal stenosis, but I've never had any symptoms. So the easy thing is, if you have zero symptoms and imaging that says spinal stenosis, then there's nothing to do. And, you can't tell someone, you have spinal stenosis if you don't take care of it tomorrow, there's going to be a problem, because the natural history is often benign, variable, and we really only operate on people who have symptoms. So then you get to the point of, well, what are the symptoms of spinal stenosis?
I wanted to go next. Yeah, exactly.
And so it's something called neurogenic claudication, and it can be confused with other problems. But in typical neurogenic claudication, patients have back and leg pain, or back buttock and back of leg pain, or back buttock and front of leg pain, but it's usually back pain and buttock pain that radiates down the legs, that's usually exacerbated by walking. And there's often associated distance-limited gait is a specific thing that we ask. If we will ask a patient, can you walk 10 feet? Can you walk 5 blocks? Can you walk half a mile? Do you get those symptoms when you do those things? And we try to figure out, what is your distance-limited gait? I would tell you that bowel and bladder symptoms are incredibly late findings. If you're starting to develop bowel and bladder symptoms, meaning urinary or bowel incontinence or frequency or urgency, those are late findings. So the early findings are pain, sometimes numbness, and sometimes weakness. Those are the things that we're looking for, aggravated by walking. The differential diagnosis is vast. It includes things like peripheral neuropathy, like vascular claudication, which is obstruction or narrowing of the blood vessels to your legs, and many other things as well. But in typical patients with spinal stenosis, they have neurogenic claudication, and they present to a physical therapist, neurologist, neurosurgeon, and it's really a matter of saying, how bad are your symptoms? Is it affecting the quality of your life? And if it is not, or the symptoms are minor, definitely a route of conservative care is the initial thing. And that can include physical therapy, medications, acupuncture, stretching, Pilates. There's a vast list, and none of which I'm an expert in. And so I usually, when I'm talking to a patient, talk about all of these different options and make referrals, including for injections, which you talked about. And an injection, epidural injection, usually means taking a needle and putting it around the spinal canal, sometimes in the spinal canal, sometimes below the spinal canal or on the side of the spinal canal, lots of different options. And injecting usually steroid and local to kind of numb the nerves to see if it provides any relief. It's typically done by a pain management specialist, anesthesiologist, physical medicine rehabilitation. Sometimes surgeons do it, but often not. I don't. I just do surgery. But it can be helpful. It can relieve symptoms. It can relieve symptoms for a day, a week, a month. Sometimes I've even seen a year or two where patients have gotten relief. There's usually a maximum number that you can have per year. Usually what's quoted is like 3 per year. The downside is very low, I would tell you, but not zero. I've seen people get hematomas or infections from the injection, but I would tell you that's very rare. I've also seen people who've had like 30, 40, 50, 60 injections, and I would tell you that's too many.
Yeah.
Once you've had that many, you tend to get a lot of scarring in your spinal canal. And if you end up having surgery, it becomes more complex. So
Yeah.
that's the whole point of injections, and they can be diagnostic. You would expect that people's symptoms would get better, at least temporarily, but sometimes they don't, and they still have symptomatic spinal stenosis.
And you brought up a really good point. And this is why I was very excited to have you on the podcast, is to be able to talk about the continuum from what we see in the movement behaviors and the pre-existing behaviors that might lead to it or might exacerbate some of the congenital components of the spine. And then really understanding that progression, because what I find so challenging, like you said, you could find your intervention with a physician anywhere, but what I find challenging is when we catastrophize as healthcare practitioners or sensationalize it to a point that it freaks the patient out. And then we have another problem, because now we have not just the neurogenic pain, but now we're getting neuroplastic pain, and we're getting other types of problems that are going to complicate the matter. Thinking of this progression going through, and let's make the assumption that we've done our physical therapy, our movement, our Pilates, we've been able to postpone what might be the inevitable in that particular person's pathway. You've ordered the epidurals, you know that there's a diagnosis there of the stenosis, you know that it's causing some neurogenic problems. Let's talk a little bit about the surgical procedures. And of course, this is your specialty. Where do we go, and how do you make decisions based on, you had mentioned like it could be stable. In my case, the structure was good, but it was really, really hypertrophied and compressing the canal, versus somebody that is unstable that might need something more structural, as in hardware or reconstruction of the spine. Talk us through a little bit about just your way of thinking as you go through and look at that. What determines that instability versus stability?
Perfect. Yeah. I'm going to preface my answer by saying that if you go to see a neurosurgeon or an orthopedic spine surgeon regarding surgery, it isn't uncommon to get multiple responses, multiple different procedures being proposed. And I think that's disconcerting for a lot of patients, because they figure, well, medicine has got to be pretty, should be very clear what needs to be done, and everybody should be saying exactly the same thing. And I would tell you that isn't true. And I think a lot of it is influenced by training and experience. And I think that my answer has got to be prefaced by those comments. I would tell you I tend to be relatively conservative. And it's not to say that we only do small surgery. There's a lot of big surgery that's needed. Someone who has very severe deformity, you can't do anything simple. But in a lot of people, I would say most people, you can just do what's called a laminectomy. And a laminectomy simply means removing the bone at the back of the spine. It could be L4-5, it could be L2 to L5. It depends which levels are involved. And that just leaves more room for the nerve roots. And that has been around for almost 100 years, I would tell you, or more. And it works well. There are risks, and we can get into the specific risks, but that is definitely one of the sort of standard options. And that's usually done through an incision in the back where you have to make an opening in the skin, and you have to push the muscles to the side to be able to get to the bone, and then you just remove the bone. Now, there are variations on the theme. There are minimally invasive approaches where you can do a similar thing through a tube. There are endoscopic approaches that are being developed to do, again, similar things through smaller incisions. A bit of it depends on how extensive your stenosis is. Especially if it's one level only, you might be able to do that. And again, this has a lot to do with training and as to what people would recommend. There is something called a mild procedure, which is usually done through a needle. I would tell you, at least in my experience, I haven't seen great results with that because it's really too small of an incision, not enough decompression. And so to get to the question about stability, and I am probably going to oversimplify it here, but in certain cases, you'll have a patient who has a slip or spondylolisthesis, and that means one vertebrae is riding forward on the other by a significant degree. The medical term is spondylolisthesis. The sort of layman's term is slip. And in those cases, we have pretty good evidence to suggest that if you don't do a fusion, that you will be back for additional surgery sooner rather than later. So if you have a grade 1 or grade 2 slip, as well as the spinal stenosis, you're probably going to need a fusion along with the decompression. And again, some of those things can be done minimally invasive. So fusion doesn't necessarily mean huge surgery. And that's sort of the oversimplified version on surgical options.
I like that, actually. And I know I've talked to you about spondies before and that relationship. And I didn't put it together, though, that was where you're looking at my spine, for example. You were pretty confident that it was stable and didn't need hardware. And now that makes sense to me as far as I appreciate that. And I think for the audience listening is quite often people will have spondylolisthesis and also can be asymptomatic. They don't have any symptoms. So again, it's when the symptoms present and looking for solutions when it's interfering with the quality of your life, your ability to work, your ability to do your daily activities. There was a study that came out, Dr. Levi, in 2018, I think, a meta-analysis that was looking at surgical options for lumbar spinal stenosis. And the conclusion on it was that, obviously, they always say we don't have enough evidence, but they looked at thousands of studies and just did not see a significant difference between the traditional laminectomy and some of the other neurosurgeries and implants and lifts and those kind of things of the long-term outcome. And they looked at patient satisfaction, they looked at radiographic information, and as well as just return to function and self-efficacy scales and those kind of things that were part of their criteria in their Cochrane procedure. When you're looking at the new procedures that are coming out, and there's always something new, where are you seeing that going? Because I see a lot of hype. I have patients coming in, oh, this doctor wants to do a lift, this surgeon wants to do that. A new procedure, an anterior approach to do an artificial disc in the lumbar spine. The literature seems to be showing that there's some good results. Any thoughts on that you would want a patient or a physical therapist like me to know and to be able to educate?
Sure. Yeah. So I was actually involved in some of the original IDE studies for cervical discs. And so that was actually back in 2001. So that was like a quarter century ago. And we were enrolling patients and they had very defined criteria. They had to have a mobile disc space and they had to either have myelopathy or radiculopathy. And it was a prospective randomized study. And you either got a fusion or the artificial disc. And, the results of that study were pretty clear that patients did as well or even better with an artificial disc, and that the risk of adjacent level disease, which is something that we worry about when we do fusion, was less. And we published the 10-year data. There is probably more data about artificial cervical disc than there is in anything we have in spine. But the issue is you have to have a mobile disc, and mobile means that it moves on flexion extension. And it is usually surgery for young people, like in the ages of 20 to 50. If you're older, if you're almost fused at that level already, if you have a broken neck, you are not a candidate for that. And so sometimes what I see is people being offered that when they're just not the best candidates. And if you're not a good candidate, unfortunately, what's going to happen is you'll end up fusing anyways at that level. So that's cervical. Now, lumbar artificial disc, which is actually something that I do not do, but some of my partners do, is really designed for people who have degenerative disc disease that is causing mostly back pain and not leg pain or nerve compression. And, you could have a 1 or 2 level artificial disc in a properly selected patient who's failed all conservative treatments and has the appropriate sort of changes on their imaging, and they can do reasonably well. I think it's been hard for insurance companies to approve that procedure. And so I think that's a part of the reason why it hasn't been sort of universally used. The advantage, again, of doing something like that is if you continue to move at that level, you should have less adjacent level disease. And just for your audience who probably doesn't necessarily know what that means, is that, sometimes if you do a fusion, you can have more wear and tear on the levels above and below. And so that's why that artificial disc technology and the appropriate people who are still moving at that level can be an option.
Yeah, I've had a number, probably some of your patients as well, that have come in with the cervical artificial disc that have done just incredibly well. And one of them was a young ballet dancer, probably in his late 20s, and it was like he was in and out, but he did so well. It was amazing that he had just severe radiculopathy in his right arm, and the next day after surgery I saw him and he was already feeling much better, and within a couple months he was back dancing again. And we do see the adjacent joint problem quite often in physical therapy with fusions. And that again goes back to where my strategy, and this is where I'd love to sort of take the discussion now, is to create additional strategies of movement to prevent adjacent joint syndrome when there is a fusion. And that we've been able to be pretty successful in that it does take a higher skill level. And so I don't just tell people to, oh yeah, let's go teach how to change the strategy moving your body, but pretty basic way of describing it is like, if I know that I had a cervical fusion or a lumbar fusion, I might look at changing strategy of how to use your thoracic spine for rotation more, or how to get more extension out of your thoracic spine, or even flexion out of your thoracic spine to minimize the stress and load on the adjacent joints to the fusion. And what we do see is that people have their behavior and their strategies. So just because they have a surgical procedure doesn't necessarily change their strategy or behavior. And trying to make everything stay rigid also is not a good solution. So it's like trying to find some way of educating distribution of movement in other joints that can prevent that adjacent joint syndrome. Do you have, and let's come back to the stenosis post-surgical, let's say that there's those that are just a laminectomy versus those that have a fusion. Movement protocols that you've developed over the years with your team, particularly the early movement protocols. And what I'm really talking about are going to be precautions and restrictions that you issue as the surgeon. And then just sort of looking at what movement practitioners, I'm sure there's a lot of physical therapists as well listening to this podcast and Pilates teachers alike. What are some of the concerns with the precautions? But I think it's important to have the communication between us and the surgeons to be able to be in the best interest of the patient of when is the critical time that we should not be doing anything with those tissues, and when do you relinquish that into some good hands of teaching movement and restoring movement? Maybe we start with laminectomy and then we move into fusion and maybe multiple level fusions. Still talking about stenosis.
So with laminectomy, you're decompressing the nerves at the back of the spine. So you're just removing the lamina and the spinous process, and then you're sewing the muscle back together. And I typically say to my patients, no bending, lifting, or twisting, for the first 6 weeks within reason. Obviously, you cannot possibly live without doing any of those things, but just no BLT within reason. They don't need a brace. We don't want them to have a brace after a laminectomy. And there's all different types of laminectomies. There's like 1 level, minimally invasive. There's 5 level open. Everybody's different, and everybody has different physiological startup point. Some people are totally out of shape. Others are in great shape. Early on in the first,
didn't want to do anything.
But then I would say in 6 weeks, you should be ready to start resuming a more normal life. And we will often prescribe physical therapy for patients if they feel they need it. Some people say, I don't feel like I need it. I always encourage them to do it, even if it's just for a short term, just to get some appropriate instructions for the future on how to keep your back healthy. So that's what I would tell you for laminectomy. For a fusion, essentially what a fusion means is that you want the bones to meld together, one bone to another. And you're actually asking the body to grow bone between their 2 vertebrae. And the instrumentation that's placed, if that's what's needed, is simply there to immobilize internally your bony structures so the bone can, creep from one level to the other. And we typically tell patients that process takes 12 months, but usually within the first 3 months, it's usually about 80-85% complete. And so the typical on those types of patients, and everyone is different. So, people are having 1 level fusion, others are T10 to the pelvis. There's so many different variations on the theme, but typically we do bracing, and those braces could be anywhere from a hard shell brace to somewhat hard to a very soft Velcro brace. It all depends on the different surgeries, but we pretty well want them immobilized for 3 months, weaning out of the brace after that, and then going to physical therapy probably week 16. That's I would say is the typical. And the reason why we want that is we want to immobilize that abdominal lumbar segment so it gets the best chance to heal.
And that makes a lot of sense. And I also appreciate the concept of condition and deconditioning of the actual patient, the age, if they have other comorbidities that everybody's unique in their recovery from these surgeries. And I think it's important that, like, for example, in our clinic, I don't like to have real hard protocols. I like to have guidelines. And the guidelines are based on what that patient presents with. And I think that the communication between us is so important to understand some of the unique variables, like somebody that has a connective tissue or autoimmune disease that's, the tissue is going to take a lot longer to heal than it would if they didn't, or if they had diabetes, or like you say, in the multiple levels versus a single level, and age, and if they're very deconditioned. So I do think all of those variables do need to come in and patients do need to have that consultation of really being honest with where they are and where they need to go and the time that it takes for the tissue adaptation and healing to occur. So I appreciate that clarity. As we sort of come to a close, Dr. Levi, what are some things that you would maybe advise people to look for and therapists as well to refer to when we're coming across some of these symptoms that are not resolving with traditional physical therapy, maybe even with the epidurals? What would be some advice that you would give as far as looking for the right provider in their city? I mean, we're in 80 countries, so whatever you're saying here is going to go all around the world. But just so more looking at like what are things that you would want your patients to be able to discover and find in a neurosurgeon.
And so I would say neurosurgeon, orthopedic spine surgeon, you want someone who is a specialist in that area. Back, 30, 50 years ago, I think as neurosurgeons or orthopedic surgeons, people felt they could be the jack of all trades and they could fix a hip, a knee, a back. It's all the same thing. And I would say it's probably good to have someone who just does that. And you just need to see that type of person because, a lot about is experience and reps. And you need to have someone who's seeing the same thing or similar things a lot to get good at things. So that's what I would say is number one, is someone who specializes in spine surgery. Then after that, I think it depends a little bit on what the problem is. Like if the problem is pretty routine, then I think, you could go to multiple spine surgeons and get good outcomes. If it is uncommon and it includes things like deformity or tumors or infections, you probably want to go to somewhere where they see those rarer things. And after that, I think it's always good to get potentially a second opinion. And like I said, you really want to hear hopefully the same thing from two different providers, but it could be similar and not identical, and it still could be okay. I would be wary of the surgeon who tells you you need to have surgery tomorrow, otherwise you'll be paralyzed. That is something that I hear too often, I would tell you, and I don't think that's the right message for most things. Most things do need some kind of conservative care. Now, on the other hand, I see people who run the opposite way. They don't want surgery, and I respect that. They try everything possible. They become chronic in their pain, and they're 2 or 3 years out from their condition, and they say, okay, I guess I'll do surgery. And I would tell you there's a possibility that you might at that time not get better with surgery, because if you have chronic nerve compression, sometimes if you relieve that pressure, the nerves have been changed or damaged, and the outcomes are not as good. And there's certainly a lot of papers out there that suggest that it's not good to wait too long. So somewhere between those two ends of the spectrum is where you want to be.
That's such good advice. And, the thing that we see so often in people that wait too long is they start having the neuroplastic changes where anything, pressure, temperature changes in that region start being identified as stimulant for pain when there's no tissue damage. So it's like even if you do correct the problem surgically or through rehabilitation, if they wait too long, sometimes it's now a completely different beast and much harder to work with. Any last thing you want to share with the audience?
No, this has been a lot of fun. Thanks for inviting me. Great seeing you. I haven't seen you in a while. I'm glad to hear you're doing well.
Dr. Levi, thank you so much. I'm super grateful as a physical therapist in the community for the great work that you and your team do, from a customer service all the way to the physician you referred me to for the epidural, to your residents. Just a kudos to your whole team, your support team. And also, as a physical therapist in the community, you've done great work and a great leader, and we appreciate that. As we bring this to a close, above all things, we want to remind everybody to live aligned and be kind. Thank you, Dr. Levi, for joining us, and we'll bring you back with another pathology in the future.
Sounds good.
Thank you.
Okay, bye-bye now.
Thank you for joining the Live Aligned podcast. If you like what you hear, please let us know by leaving a review on your favorite platform. If you have comments or questions, please leave me a message at drbrentanderson.com. You can follow me on Instagram at drbrentpt. To take a deeper dive into the science of movement, check out my new book, Principles of Movement, available on Amazon. Live Aligned Podcast is produced and edited by Gabe Anderson. Music and sound designed by Delver. Additional production assistance by Katrina Bond and Nicole Conrad. Special thanks to my team, Elizabeth Jimenez, Melissa Pereda, Cesar Maya, Gary Bentz, and Charlie Zuckerman. I also want to thank the team at Polestar Pilates for sponsoring and supporting us with technology, marketing, strategy, and much, much more. Thanks again for listening. Live aligned and be kind.